My name is Naval G. I'm one of the leukemia faculty at MD Anderson Cancer Center in Houston, Texas. I'm here presenting from the ASCO 2017 meeting. I'll be telling you some of the highlights of one of my posters, which is a combination of azacitidine and a PD-1 inhibitor, Nivolumab, in patients with relapsed AML. So as most of the oncology community is aware and excited, there has been an explosion of immune therapies, including PD-1, CTLA-4, PD-L1 inhibitors, showing excellent responses and durability in many solid tumors and hematological malignancies. We are one of the sites that has started investigating these in a large way in acute leukemias, including AML, MDS, and also in some forms of chronic leukemia, such as CLL. One of the first things we had done as a background before we started the clinical study was to look at 100 patients with AML. Half of these were relapsed and half of these were newly diagnosed, to see what is the expression of PD-1 on different T-cell subsets. And we actually did find that there was increased PD-1 expression on the CD8 cells as well as the Tregs and CD4 effectors in AML bone marrow aspirates as compared to healthy human donor bone marrow aspirates, which was interesting, indicating that there is a immune exhaustion or immune activation that happens in acute myeloid leukemia. After this, we went ahead to start the study, which was a combination of standard azacitidine at a dose of 75 per meter square, days 1 through 7, which would be what we would use as an HMA in AML. And to that, we added the PD-1 inhibitor, Nivolumab, on days 1 and 14. Initial part of the study had a safety run-in with 6 patients, and we saw that there were no major DLTs or concerns, and so the established dose was the combination of AZA and Nivolumab, both at their standard doses. We then went ahead to the expansion and went on to enroll an additional 64 patients, so a total of 6 plus 64, 70 patients, and that's the data we have presented over here. So as you can see, if you look at the poster, the background characteristics, these are elderly population. They have a median of 2 prior treatments, so all of these patients were salvage AML. We did not include any frontline AML in this study, although there is an extension of this study now looking in frontline elderly AML. Also, very similar to what we see at Anderson, we did have about 1/3 of population that had adverse cytogenetics. So these are usually difficult to treat people. And we did have molecular profiling on all of these patients. And we saw that the common mutations were TP53, ASXL1, DNMT3, of which TP53 is important because it is a high-risk resistant mutation. So what is important in this poster was what was the overall response rate and the durability of the responses. So the response rate, as you can see, is about 32%, which included a majority of CR/CRIs, about 22%, and then hematological improvements, which we only included if they were durable for 3 months or more, and that was about 11%. Another finding that we saw that has been well described in solid tumor was there was a subset of patients who did not achieve a CR/CRI or hematological improvement, but achieved stable disease. And in some cases, this has lasted more than 1 year without transplant, which in a relapsed AML population is quite unique. And we are trying better to define how we would call stable disease in these heme diseases, as we have done in other solid tumors with immunotherapies. We then compared what these outcomes looked as compared to using azacitidine or decitabine alone in salvage AML. And what we saw is that the overall response rate that we saw was about double. So in our historical group at MD Anderson treated with AZA or DAC alone in salvage AML, the response rate CR/CRI were 11 to 12%, and in this group we had about 20 to 23%. In addition, the median overall survival as well as the progression-free survival to next treatment were significantly improved. And as you can see in figure 2 in the graphs, especially among patients who were salvage 1 AML, we saw a very encouraging median overall survival of almost 10 months. Now, putting this into perspective, the frontline studies with azacitidine and decitabine, phase 3 studies, have shown a median overall survival of 7 to 9 months. So to get a 10-month survival in the salvage AML population, again, this is a single center experience, but it's quite encouraging, and we think we need to develop this further. We also did some immune correlatives, and it seems that patients who had higher CD3 and CD8 infiltrate in the bone marrow aspirate to begin with were more likely to have a response, which again goes along with what has been shown in many solid tumor immunotherapy studies. So we expect that in the future we will be able to define maybe biomarkers to select the patients who would benefit most and have a high response rate, allowing other patients who have less T-cell infiltrate at the baseline in their bone marrow to go to molecular or cytotoxic therapies. I will stop here and thank you very much.